Right. So thank you everyone for joining. We have a nice interview with Associate Professor Mikkel Mylius Rasmussen from Aarhus, Denmark, which will be focusing on the more academical part as opposed to the other interviews we have. So the topic for today's presentation would be on patient demographics and selection in degenerative spine disease. My name is Radesh Mishkov. I'm a medical resident in neurosurgery at Aarhus University Hospital in Denmark. And together I have my two colleagues.
Hello, I'm Maria Laura Giamundo. Nice to meet you. I'm also a neurosurgeon and I'm working in Switzerland as a spine surgeon.
And good evening, my name is Sam. I'm a medical student from Thailand.
Perfect. So, Mikkel, before beginning, could you please tell us a bit about your position, years of experience, and area of expertise?
For sure. As you said, my name is Mikkel Mylius Rasmussen. I'm a consultant neurosurgeon at Aarhus University Hospital and an associate professor at Aarhus University, in all of it in Denmark. I finished my formal training in 2015 as a neurosurgeon. And after that, I've become more and more dedicated to spine surgery. And I'm fully dedicated to spine surgery and also to spine surgical research, where I'm affiliated around 40% of my time to that area.
Fantastic. And could you please tell us a bit about your roots, maybe where you grew up and how did your childhood influence you as a surgeon?
Always nice to talk about yourself. Basically, I come from a small town, Denmark, the countryside. No doctors in the family before me. Really classic family setting with lots of love. I believe my raising taught me self-confidence, but also hard work, coming from the countryside. Realism. I know where food comes from. My father is a carpenter, and when I was taught surgery, I always heard some of his words from my childhood ringing in my ears. Focus on the matter at hand. Leave tools you don't need out of your hands, etc. So these are probably some of the abilities that has helped me building my own, at least my surgical career.
Next question. Where did you train and when did you complete your residency?
Yeah, okay. We've covered some of it, but I've trained at two Danish hospitals, the Aalborg University Hospital and Aarhus University Hospital, and finished my formal training in 2015. And up top of that, I have, during my PhD, which I did simultaneous with my residency, I had several stays in a German hospital in Bad Wildungen, which is fully dedicated to traumatic spinal cord injury patients, which taught me quite a lot about the spine field and spinal cord injury itself. I know it's not the topic of today, but it is also one of my key interests.
Right, nicely. As in, we're open to hear a lot more about your areas, Mikkel, of expertise. So, well, you've answered a bit about the other things. Why did you choose this field? Why not cranial surgery, for example?
Yeah, that is a good question. First of all, I would say my career path is probably a little bit different than many other surgeons. I'm not fascinated by tools, and I've not started being fascinated by surgery itself. My fascination was with nerves, nervous tissue, and physiology. So my way into the neurosurgical field have been through research, where I at medical school started being affiliated to research in spina bifida. And that has catapulted me into a more broad interest in first spinal neurosurgery and then spinal surgery itself over the years. And that also means that my approach to surgery are perhaps, in a lack of better word, I would say humble than some of my surgical colleagues. I clearly see benefits with surgery, but I also clearly see some limitations in it. And I would say choosing the right patient for the right treatment, you can become a hero. Choosing no surgery for the right patient, you can also become a hero. And I truly believe that our most powerful tool as surgeons is to improve outcome in spinal surgery, is to choose the right patient for the right treatment. And that ability in your careers will fully compensate for any minor difficulties you may have for specific procedures. I also believe it is the most difficult work we have as surgeons, and it is also the part of our training where we truly need clinical evaluation and where we have less of the objective tools that we may have in other parts of our careers. You have navigation, you have X-ray, but when you have to choose the right patient for the right treatment nowadays, you have basically your clinical evaluation and an MRI.
Well, that's yeah, we couldn't agree more. So it was a nice overview of the pros and cons also of being a spine surgeon. So please, Sampun.
Yeah, so thinking about your professional journey, who inspired you to be, the surgeon you are today? And was there any like reasons for that you had a mentor maybe, or any individual that inspired you to be the surgeon you are today?
That's also a great question, and thank you for it. I think like many others, I have several mentors guiding me on my journey. I have hard time picking one, so if you will allow me to elaborate a little bit, in the Danish and the Scandinavian medical institutions, you usually don't get affiliated with just one specific person that mentor you, but you are affiliated with the departments as a whole. And that allows you some advantages. You're allowed to cherry pick, if you say, and observe several colleagues do their work, great work, and let you inspire from many sources to put the pieces together in your puzzle for your own way to do your clinical work. So in my journey, I would say names like Claus Morsdal, which is now a deceased great colleague of mine, Dorte Clemensen, Ole Fetters, retired, René Laursen, Gudrun Gudmundsdottir, and Mindugas Basus, I would probably name. These are all skilled and wise colleagues that had inspired me in my chosen path. So I'm afraid I can't put one name on the table here, but there's got to be several.
Thank you. We change a bit topic. Taking into account that spine surgeons work in different settings, do you think that the health system feature, like, for example, public versus private hospitals and access to conservative treatment can influence patient selection? So we go back to the patient selection topic.
Yes, and that is great. That is also on my mind a lot of the time. Well, the way that you answer the question, I think it is difficult to answer in one way. So I'll maybe again try to extrapolate a little bit. So if you look at it one way, you could say if the question at hand is if the way a country or an institution will organize healthcare may affect treatment opportunities and thereby the individual spine surgical treatment of the given patient at hand, I think the obvious answer to that question is yes. If you don't have access to surgery, if access to surgery is limited, or the same is regarding conservative treatment, or if all costs are covered by the patient in a private healthcare setting, then I think it will, and I think it should affect your treatment offered to the patient as a surgeon. The driving factor discussed in this frame would be if the outside given frame would affect it, your decision making, and that is probably the most influencing factors for surgical choices we have. The other issue you could raise in the question is would personal gain affect your decision making? And the answer to that question is important, and I think every surgeon should answer that for themselves. I also think what could be done from a society or an organization, like your good AO spine, or as you as a surgical individual, You could try to organize, you could try to lobby the construction of healthcare in such a way that the framework is carefully created to reduce any other influence on surgical decision-making, that the one being the most important, which is that choice being the right, benefiting the patient the most. So it's a long answer to a fairly short question, I'm afraid.
Yes, but it's very nicely put. So yeah, we'll take it. So every professional has that one memorable case. So could you share a bit about yours and the lessons that you learned while thinking about patient selection in the process?
Well, yeah, there's a lot when you have a career that is going over a little more than a decade. Well, I would emphasize one then. In my early parts of my residency, I had an elderly alcoholic psychiatric patient in my care. He did not take care of himself at all. And I would say every book will tell you that this patient will not fare well in surgery. Symptoms could be, when you examine it and evaluated him, could be perceived as radiculopathy because he wasn't very good at putting in words what his real problem was. And if you perceived it as radiculopathy, you could align it with the MRI he had. So I did fear the worst during surgery, but I did do it. And he had full recovery from the surgery. So I would say my takeaway from that case is that take it up to the high level. Every patient do deserve an evaluation and to be heard. And taking it to an academic note, I think it is fairly fascinating that pretty much any algorithm you would put this case into would give you a very low chance of improvement. And I'm quite certain that the AI algorithm we have today would reject him immediately. So it is really hard to get these final parts of clinical evaluation with what is the clinical experience and what else we want to call it, fitting into those models to make them outperform current clinical evaluation. In my mind, it hasn't been done yet.
That's a fantastic answer. I'm sure that was memorable. So the next question, you are a very well-recognized research and education leader in spine surgery, especially on patient selection, which is really important. You have some ongoing studies, right, on radiculopathy and axial back pain and what the surgical indications for patient selection can be like. For example, there was the Dermatome and also the PLAN project. Could you please elaborate on what was your motivation behind initiating these studies?
Well, that is probably the best question I've had until now. So it's always nice to talk about your own research. So thank you for that. It is true that my group have a focus on patient selection, and in my mind, techniques for spinal surgery are developing quite fast. It is a little like powder for washing clothes. You get a lot, and you get a lot of them fast into the market. Also implants. However, when you evaluate them, and you can't evaluate them fast enough before a new one comes into the market, it's hard to show that much have been gained when you consider patient-reported outcome. So you could say either our measures to find patient-reported outcome are too crude, or perhaps you don't have any significant revolutions around that corner to be gained by further developing techniques at this point. So that means our best option to optimize treatment are to choose the right patient for the right treatment and to create solid evidence for the procedures we offer. So basically, we can offer decompression and alignment of correction or deformity correction in degenerative spine. So my motivation to undertake these projects is basically to produce evidence to be shared by everyone in order to increase correct patient selection for spinal surgery. Yeah, I hope that was a fair answer. Otherwise, we're gonna talk hours and hours about my projects.
That's awesome. Thank you. So another question. What is your opinion on these three pillars of expectations management in spine surgery? Trust, communication, and patient education.
Okay, so now we are moving into a little more perhaps ethical parts. Well, overall, I would say as spine surgeons, we do have the highest knowledge within spine degenerative disease. And as with all situations where you hold information others do not have, it requires quite high ethical standards to disseminate that information to avoid a high risk of manipulation. One has to be aware of one's own biases, one's own beliefs, and one's own ethics, and take that into account, and also the beliefs and the ethics of the patient you have, in order to produce a correct conclusion on what is right to do for this patient. So taking the first one, trust, it's a really double-edged sword. Overall, I would say, in my experience, patients do trust their surgeon, but that trust can be used really helpfully when you do want to help them, but it can also be abused if you're not aware of your own shortcomings. Taking the other two, you talked about communication and education. So I'd say patient education and communication is very important in spine degenerative disease. And especially in countries like most in Europe, where average age and life expectancy is increasing these years, this will be a hot topic. And this means many more patients, and thereby a lot more information has to be shared with patients on an overall patient basis. How to do this, and who should do it, and how to do it most cost effective is discussions ongoing at this point, and I think it will be discussed in spinal surgical communities, but also in the healthcare system, at least in the next decade.
So we agree completely with you that it's going to be quite a hot topic. And do you think that spine surgeons should be wary of offering surgery to the aging population?
Well, as we just discussed, average increase in age is seen in these years in many Western countries, at least. So this is a question that rises to the top of many public health agendas, how to deal with this average age increase. And that is also on the top of agendas in many spine surgical communities. In my view, I think it's quite important to distinguish between the increasing age and healthcare or health problems. So you may easily encounter an 80-year-old patient with a health very suitable for spinal surgery. And you can also encounter younger individuals where spinal surgery seems counterintuitive. So with age, more often than not, we see a correlation with osteoporosis and also comorbidity, but it's not always the case. And I think these comorbidities are really the factors that should be the driving arguments for or against surgery. So when I look at the development in spinal surgery techniques in patients with osteoporosis, which correlates very much to what you asked for about the age, I see two overall strategies developing in the spinal surgical communities. One is the correction of deformity into sagittal balance with long and large constructs. And the other is the opposite way with a minimal invasive approach, or as minimal invasive as you can get. And I don't think there's any absolute truth or any absolute correct path. And of course, you will have patients fitting for both of these scenarios. But in the majority of cases, I personally would advise to be cautious with length of surgery and surgical trauma in fragile, elderly, comorbid patients, where known complication rates with these large, long constructs are known to be in the 2-digit percentages.
All right, very well indeed. Our next question is, can telemedicine affect selecting the right patients for surgery? And what is your opinion on how useful telemedicine is for spine?
Yeah, well, Telemedicine has been brought into patient care into recent years, and at least in my part of the world. It is heavily advocated, and it is for two major reasons. One is, and I think that is also important to think about, patient demand. It is very much convenient for the patients, so they would very much like it when it's possible. The other one is budget costs. It is cost effective to have the patient at home. In my opinion, it will have a role in patient care going forward. In my mind, it's best suited for follow-up. In the first meetup with patients and when you're going to offer surgery, again, in my mind, in my opinion, it is very good to have a clinical evaluation and a face-to-face time with patients. And then again, I think the matter is again the matter of age and the comorbid patients. I think telemedicine is not suited for all. Your classical elderly patient with hearing aids and impaired vision might not be suitable for online evaluation, and one size fits all will make some patient left outside of optimal care. But I may be old-fashioned, I don't know. That could be the thing. Going back to your question, if it could affect the right patient for surgery, well, used the right way, you could probably use it to deal with more patients as an individual surgeon, which means more patients could be offered expert contact, expert evaluation, but it has to be for the right patients and it has to be in the right settings. That clinical evaluation where you offer surgery, I think, would be best left out of telemedicine.
That's very true. Thank you very much for the overview. We change again subject and we go at the end of our interview. We make a game in which we ask you a question and you reply very quickly about personal life more. So your favorite hobby?
Sorry, my hobby?
Your hobby.
Am I allowed to say research dedication first?
That's allowed.
I consider it a hobby myself, at least. But besides that, well, I like history in the broadest sense. I like historical travels. And I also think of myself as a kind of wannabe foodie.
Okay, that's a good inspiration to know. What about your favorite book?
Favorite book? Well, that also's got to be something with history. So I'm afraid it's going to be something Danish. My favorite author at the moment is a Danish author called Peter Øvig Knudsen, and he wrote a book about the Second World War in Denmark, which is called Birkedal. So anyone who speaks Danish out there, I can recommend it heavily.
Very nice to hear that. Do you have any favorite sports and a favorite sports team or athlete?
Well, that has to be cycling. And if allowed, I would mention two favorites. Jonas Vingegaard from Jumbo-Visma, which won Tour de France twice and last year got a second place. And Mads Pedersen from Little Trek, who is a former world champion.
And your favorite surgery?
My favorite surgery? Well, that's got to be the lumbar disc herniation procedure. That is the procedure that made me go into spinal surgery in the first place. It is the most giving procedure, and it is the most with most pitfalls. It still can be complicated, even though I'm several years into spinal surgery.
And if you were to choose between navigation and freehand, which would you take?
Navigation. Always navigation.
Always.
Nice to hear that. If you could choose only one word to define spine surgery, what word would that be?
I think challenging. Challenging all through your career.
Yeah, I agree.
Totally agree.
Yeah. And if I should find a word to describe this interview, it would be very pleasant and very enriching. So thank you, Mikkel, for finding the time to speak with us and share your thoughts on spine surgery. So you'll be a source of inspiration for our colleagues and members in the youth club. And it's been a true privilege to have you here.
Thank you for having me. And if anyone have any questions, feel free to reach out.
Thank you very much.
Sure.
Thank you.
Thank you.
Yeah.